It's my pleasure and honor to introduce again our honored guest, Dr. Edward Oldfield, who will present the third of his presentations, this time on spinal, dural, arteriovenous fistulas, 40 years of progress and unanswered issues.
Thank you, Nader. Thank you very much, Nader. Let me take this last opportunity to congratulate Russ Lonzer for his effective leadership of this strikingly successful meeting. My comments are going to be focused to a certain extent on what we still don't know about spinal dural AV fistulas. The initial studies of spinal AVMs were all pathological, and based on those studies, the great majority of spinal AVMs were considered to be venous in origin. With the introduction of selective spinal arteriography in the mid-1960s, the site of the nidus of the AVM was clear in two types, a type called the glomus and the other type called a juvenile spinal AVM, but not in the type 1. And one of the reasons that these abstract terms were used to define the AVMs was because they really didn't understand what was going on with the most common type, type 1. Now this type was known to be usually entirely extramedullary, primarily on the dorsal surface of the spinal cord. It was seen only in adults. In most instances, there was only one feeding artery. Flow through these lesions was noted to be very sluggish compared to the other types of AVMs. The transition from the arterial to the venous element was unclear, though. It was theorized that it was along multiple connections in the pia on the surface of the spinal cord. And surgical treatment of these became stripping of the abnormal vessels on the back surface of the spinal cord. In 1977, Brian Kendall and Valentine Logue in London described a series of patients in which they had identified that the site of the dural AV fistula was in the dura, and that the process of what was happening intrathecally was just a side effect of the reception of the arterial blood under high flow. The anatomy of the normal vasculature of the spinal cord is that the intervertebral artery has three branches. The branch of that artery that supplies the spinal cord is the medullary artery, the dominant member of which is the artery of Adamkiewicz, but there's 8 to 12 of these arteries along the long axis of the spinal cord. So it's a sporadically present along the individual levels of the spinal cord. But at every level, the nerve roots are provided blood by radicular artery. Now, I should mention that there is no such thing as a radiculomedullary artery. Blood vessels either provide supply via the radicular arteries to the nerve roots or the medullary arteries to the spinal cord. There's no overlap in those distributions. The third branch was a small branch that provided blood supply to the dura. Manelf and his colleagues studied that latter branch in some detail using injections and showed that the spinal artery providing blood supply to the dura was clustered right around the nerve root sleeve. But there were long dural vessels that provided collateral flow from each level above and below. The venous drainage of the spinal cord was very completely analyzed by the woman who taught me neuropathology, Dr. Gilliland. And what she described was that the initial venous drainage of the spinal cord is by radial veins, which carry the blood to the cord surface into the coronal venous plexus, and that is drained into the extradural venous system by medullary veins. The medullary veins pass laterally and penetrate the dura just next to the dural penetration of the nerve roots. Now, there are no valves in the intrathecal venous system. So when we began to study those in the early 1980s, our proposal was, and our conclusions were, that the dural AV fistula is actually drained by a medullary vein that's now carrying blood retrograde to the normal route of flow into the coronal venous plexus, which now has high flow under high pressure and produces the myelopathy associated with these lesions. So we're seeing here a patient with a dural AV fistula at T9, and you can see from the duras here. This is the nidus of the feeding vessels embedded in the external layer of dura. If we retract that back, we can see that these vessels converge into a medullary vein, which penetrates the dura contiguous with the nerve root and carries that arterialized blood into the coronal venous plexus. The pathophysiology of these lesions has been known for some time to be venous hypertension, which produces myelopathy. Because of that valveless intrathecal venous system, it's very easy for the arterial blood, the pressure of it, to reach the spinal cord. This was actually proposed by Kendall and Logue in their original report on the dural AV fistulas. They also proposed it was compromising the perfusion of the spinal cord, leading to the myelopathy, and was actually confirmed by a study done by Werner Hassler in Germany. He measured the intrathecal, the pressure in the coronal venous plexus in these patients, and showed that it averaged about 75% of the concurrent mean systemic arterial pressure. But there's another piece to the pathophysiology of spinal dural AV fistulas that has received much less attention, and that is that these patients all have strikingly deficient medullary venous drainage. Now I'm going to show you, in this arteriogram, we're going to look at the normal medullary veins in a patient who end up having a normal spinal arteriogram. This is not something we commonly see, but as you watch the flow through this normal cord, you can see medullary veins leaving the intrathecal space into the extradural venous space there. That's unlike what we see with patients who have congenital arteriovenous malformations, such as patients with the juvenile type AVM. This is not the same patient, but if we follow the arteriogram in this patient, you can see that the blood rapidly leaves the intrathecal space into the extradural venous system. We occasionally also see that in patients who have acquired vascular tumors of the spinal cord, such as this patient with von Hippel-Lindau disease and 2 hemangioblastomas. You can see that the venous drainage from the larger one leaving the canal into the epidural venous system. But we never see that with patients with spinal dural AV fistulas. This is an example of a patient who has a dural AV fistula. He's got a myelopathy and a dural AV fistula at the site shown by the arrow there. And we can see with this arteriogram that once that vein intrathecally begins, the coronal venous plexus starts to fill, it has the blood in it has no place to go. It's going all the way up to his head. And then if we follow it long enough, it still can't find an outlet. It starts coming down the spinal canal. And in this patient, it goes all the way to the sacrum before it can find a venous outlet to carry that excess of venous arterialized blood away. This patient has a AV fistula of the filum terminale. You can see the effects of the venous congestion on the spinal cord there on the MRIs on the left. There's the AV fistula at the mid-lumbar area. Initially, the blood's flowing down. There's a very long anterior spinal artery from the Arteriovenous injection. It goes all the way down, feeds that AV fistula in the filum. And then if you look at the image in your upper right, you can see that the excess blood flow and vascular changes proceed all the way up to the lower brainstem. In this very interesting observation by Dr. Sato and his colleagues, they noticed in a large series of patients with spinal MRIs that they had 2 patients who had abnormal vasculature shown on the MRI within the intrathecal vasculature, but had no symptoms. When they did arteriograms on these patients, this is one of them, they had a spinal dural AV fistula, But the thing that had kept them from developing symptoms was that there was a single medullary vein that was still open, carrying the blood under rapid flow away from the venous system, protecting the cord from the effects and protecting the system from venous hypertension. What might be the etiology of spinal dural AV fistulas? These are lesions that occur in the latter half of adulthood, so they are almost, and there are other factors that show us that they are clearly acquired. If we go back to Monell's study, one of the observations that he made was that there are two very unusual small arteries in the dura, the spiral arteries, and a small cluster of glomus of vessels, of glomerulus, that he called the pelotron. And the pelotron actually could represent, if that was thrombosed and recanalized, and those things are clustered around the nerve root dura, it could lead to a dural AV fistula. But also, if the process started with venous hypertension, the back pressure from the venous hypertension could obliterate that pelotron and then lead to recanalization of it through a dural AV fistula. That's all the information we have today, though, about the source of the potential source of dural AV fistulas in the spine. Surgery for these lesions is very simple. All we do is interrupt the vein, the medullary vein, draining the dural AV fistula. And if it is the only vein draining that dural AV fistula, the fistula will thrombose and then fibrose and be permanently eradicated, as shown in this study that we did at the NIH and that John Afshar reported. Knowing the anatomy of what's going on with these lesions can help us effectively treat lesions that look formidable on the arteriogram. This patient had a fairly extensive and abnormal intrathecal vasculature, and it looked like his surgery might be quite challenging. But if we look at what's going on here more carefully, we see that on your left there, the injection at T6 fills a medullary vein carrying the blood to a very extensive abnormal venous intrathecal vasculature. But there's also blood supply from the injection at T7. The injection at T7, though, just fills one of those long dural arteries that carries the blood within the layers of dura up to T6, and then it empties into the intrathecal space at the same level as did the shown by the injection of T6 itself. So at surgery, we could follow that vein within the dura from the external nidus here up to T6. You can see the two clusters of abnormal vessels in the dura here. And all we had to do with this patient was to interrupt the vein coming in the intrathecal space at the level of T6. What about the use of embolization of spinal dural AVMs? One of the patient groups for which this is not an option is those who have a common blood supply between the arterial blood supply to the cord and the AVM. Now, this happens with some frequency because most of the spinal dural AV fistulas arise in the same region in which the artery of Adamkiewicz arises. Like this patient. The small arrowheads there show us the artery of Adamkiewicz filling the anterior spinal artery, and that's overlapped by the venous filling of coming from the spinal dural AV fistula. At surgery, all we needed to do was interrupt that vein, draining the intrathecal, the arterialized blood intrathecally, and if we look just beneath that nerve root, we can see the artery of Adamkiewicz. Surgery permitted us to very precisely interrupt that vein without affecting the arterial blood supply to the spinal cord, eliminating the dural AV fistula, but retaining the normal arterial perfusion. Now, I've gotten a little bit behind with these slides, so I'm going to move ahead very rapidly. The objective of the embolization of these lesions is the same as we have at surgery. We want the glue to get into the proximal portion of the medullary vein, draining the dural AV fistula. And that is successful in some instances, but not all. And even if the onyx does get into that intrathecal proximal medullary vein, it occasionally recanalizes around it and the lesion recurs despite what appears to be successful embolization. In the studies that have compared the success of embolization with surgery, such as this series by Dr. Eskander and his colleagues from Massachusetts General, they had no recurrences with the patients treated surgically, but there was a 60% recurrence in the set treated with embolization. Dr. Steinmetz, in his review, meta-analysis of the published literature on surgical versus embolic treatment of spinal dural AV fistulas. Now, I've forgotten left my glasses in my room this morning, so I can't read what's on there. I'll let you read it. The summary, my own summary of the treatment of spinal dural AV fistulas is that embolization cannot be used in patients with common blood supply to the dural AV fistula and the spinal cord. The obliteration of the shunt permits early clinical improvement, but the recurrence rates are fairly high. And this is a procedure that usually is done by experts. On the other hand, surgery is safe, effective, it's permanent, and it can be done. The surgery is very simple in these patients. It can be done by everybody in the room. And sometimes it needs to be done urgently at sites in which there is no specialist in embolization. So we still have unaddressed issues. And what is the basis of this limited venous drainage? Is it congenital or acquired? Is it a consequence of the arterial flow in the coronal venous system by the spinal dural AV fistula, or is it the cause of the spinal dural AV fistula the venous congestion itself? Why is the venous drainage of these dural AV fistulas always intrathecally rather than extradural? And why are almost all spinal dural AV fistulas located at the nerve root sleeve? So these issues, I hope there is somebody that will investigate these down the line and provide us with the aesthetically pleasing answer to these unaddressed issues. Thank you.